So this is the territory where I work. The triangle at the top is the hospital, and all the little villages that have yellow places, those are the villages that we serve. So you get a call from the village nursing station. This is a patient that they have there. You haven't seen them. They're presenting with polyuria, polydipsia, fatigue, nausea, and vomiting. They do the finger stick glucose, and it's 375. Which is about 20 for the Canadian units, and a patient has a history of DKA in the past. Baseline renal function was normal at the last time they had any labs, so that's reassuring. But obviously this patient is hyperglycemic. But the question is, are they in DKA? If they're in hyperglycemic, maybe they can just stay. But if they're in DKA, they don't want to stay in a nursing station where there are no labs and no 24-hour care. So they're going to have to come to us. So they call the medevac plane. But unfortunately, it's bad weather, because it always seems to be bad weather when we have someone we need to transfer. And it's going to be 7 hours before this patient gets to your hospital. So the classic DKA presentation, we all have been taught how to take care of this in the big city centers, right? And we're trained to recognize all the signs of DKA. There's volume depletion, there's confusion, there's the acetone breath, and there's Kussmaul's breathing. And we've been trained to recognize this as a serious, potentially life-threatening emergency. And we act very efficiently. We ship them upstairs to the ICU. And when they're in the ICU, they end up looking like this often. They have central lines, art lines, insulin infusion, intubation. They might be intubated, ventilated, could be on a cardiac monitor, and they're getting lots and lots of labs drawn. They're having their potassium and their sugars measured frequently. And they probably have a Foley catheter. So that's what it's like when they get upstairs. But this is where I work. We don't have an upstairs. So this is a bit of a problem. So it's a 28-bed hospital where we care for about 16 acute patients. There's no ICU, there's no step-down units, there's no specialists, there are no RTs, and probably for a lot of you who work in rural areas, this sounds pretty familiar. But it isn't fancy, but despite that, we do have labs, so we have that going for us. But what are you going to do if you're in an outpost, or you're in a nursing station, or you're helping a nursing station deal with a patient where they have no labs and there's no ward? So what is available? In our nursing stations, which are part of a network, they always have nurses, and then occasionally there are doctors. And there aren't any labs, as I've said. But actually, I'm lying just a little bit, because there are a few point-of-care labs. And my point today is that these point-of-care things can really make all of the difference. Our nursing stations are equipped with the finger stick glucose test, the urine dipstick, we have bedside serum ketones, and we have cardiac monitor, obviously, and I'm going to get back to that. It doesn't seem like much, and it certainly isn't ideal. And of course, we're going to want to get our patients to somewhere there's more definitive care. But as any rural doctor knows, sometimes life and weather conspires against us, and we're stuck. And so we have to know how to manage these patients for many hours at a time, particularly in DKA, when some of the first 6 hours, you can have some of the worst sort of cerebral effects. So you really want to make sure that you can have a strategy to deal with this. Now, this is our standard algorithm for managing DKA, right? It's very nice and straightforward. But does this go out of the window if you don't have access to labs? Now, if you're in the big city center and you've been trained that you have to have all these things in order to manage this patient safely, you might think so. But the answer is no, and most definitely not. We can take care of these patients relatively safely and still manage to get them shipped out in a relatively stable state. So I'm going to break it down today into the different elements of care, like from this algorithm, and show that while it isn't the ideal way to manage the patient, we can certainly do a lot. And you need to have a strategy, because when they come in, you need to have figured out what you want to do. So even if you don't have labs, I think most places in the world will have one of these, right? Like a finger stick glucometer. We need these for many reasons. Obviously, if there's a patient confused, they've had a seizure, all sorts of things, you're going to want to have a finger stick glucose. And it can be a lifesaver. So if you don't have one, please get one quickly if you can. But hopefully your triage history and your triage nurse is going to help you, because they'll have taken some history if they're not too confused. Maybe they have some history of polyuria, polydipsia, blurry vision, fatigue, all the things that you're already thinking, okay, I need to do a glucose on this patient if it hasn't already been done. Of course, you need to be careful, because some people who are habitually hyperglycemic can walk around with sugars that are crazy high, and they say they have no symptoms. In fact, they feel terrible when their symptoms go low for them, which would be, for many of us, putting us into a coma, but they feel fine. So you have to really watch out. So it reads as high when you do the finger stick glucose, meaning it's unmeasurable. Well, what's a first instinct, first thing to do is to give insulin. Let's fix that hyperglycemia. But we don't want to do that right away. We need to assess our patient's volume status. Sure, fancy art lines can help do this, but we can also use our clinical skills for those of us who don't have access to an art line setup. So what are some of the clinical skills that we're going to look for? Well, there's decreased skin turgor, dry armpits, the dry oral mucosa, low JVP, tachycardia, and if it's really severe, if they're really really hypovolemic, then they might be hypotensive. Of course, you're going to want to try and get these people rehydrated as quickly as possible. And these people are going to be, they're going to need a lot of fluid if they're in DKA. But even while you're just establishing whether they are in actual ketoacidosis, you're going to hang some fluid. So I would at least hang a 500 or 1 liter NS bolus while you're figuring things out. And then you can adjust it later. All right, so there's of course a lot more things other than just the hyperglycemia, though. The question is this actually ketoacidosis? How are we going to figure out the ketones and the pH if we don't have a lab? Of course, history is important, but if the patient is totally out of it or can't provide details for whatever reason, you can turn to the physical exam. Some of the signs to look for are abdominal pain, and this is particularly useful for children. They will often complain of abdominal pain. Confusion, again, decreased perspiration, like I was saying, like the dry armpits, that also goes along with the ketonemia, dry, cool skin, and then the deep labored breathing. So the deep labored breathing is Kussmaul's, and I had a little video, but it didn't work. So I think all of you probably heard of Kussmaul's, but it can be a sign of imminent coma or imminent death in a diabetic patient. If you see someone doing this particular type of breathing, then you really, really need to make sure you start treatment quickly. So do we have any cheap bedside tests available to most of us that can help us confirm the presence of ketones? What about in the urine? Now, for as long as I've been in practice, which is more than a decade now, we've always checked the urine of anyone who comes in where we suspect DKA, right? We're looking for ketones. But how reliable is that test? And can we actually be basing our treatment on it? Or should we be basing our treatment on this? The British Journal of General Practice looked at a bunch of different issues with urinalysis, and they found some things that certainly raised some concern. Of course, urine ketone strips are quantitative, so it's not an ideal measurement. The measurements don't accurately reflect conditions in the bloodstream at the time because the urine could have been sitting in the bladder for quite a while. So you may be getting sort of old and mixed information. The bottled strips can lose their accuracy. We've certainly found that where I've worked. We've had a couple of instances where we've checked the expiration dates and realized that they've gone past their date. And the results can also be affected by many different medications, so you can get false positives or false negatives. And then there's the issue of getting the sample. If the patient's awake and alert and they can pee, that's great, but sometimes if they're confused and you have to do a Foley or they're combative, this might be a whole other set of issues in which could delay the diagnosis. So if the urine strips aren't ideal, how do they compare with other methods of ketone testing? There was a study published in the Turkish Journal of Emergency Medicine in 2016 that looked at just this and found that urine ketone measurements were not as reliable as capillary blood ketone measurements. Now, of course, you're all thinking, tell me something I don't know. This is supposed to be a talk about DKA without labs, but do you hear what I said? I said capillary blood ketone measurements, not a venous sample. And so this is the bedside fingerstick capillary ketone meter. I have no stock investments, I'm not sponsored by anyone, but for me this is almost as valuable as a glucometer for a rural clinic. And you can actually even get now glucometers and ketone meters that are combined together, which is a great investment. And it costs about $40 for the actual machine, and then you have to buy the strips. But it's not a prohibitive cost when you think about the cost of transferring a patient out of your system. If we have to medevac someone by plane, it costs 10,000 Canadian dollars right off the bat. So we're obviously always trying to think of how to use our resources judiciously. So now let's say that we figured out that they do have ketones. Our little blood ketone meter shows it. Now we need to know whether they're acidotic. Unfortunately, this is the part of the equation where it gets a little trickier to figure out. When I first started working up north in Canada, in the north of Canada, more than a decade ago, I tested out a few different strategies and then repeated them again last week, hoping that maybe technology had changed and that we would find some great new way of testing pH without labs. So I thought about the pH part of the urinalysis sticks. Well, physiologically, we know that it isn't a great way to extrapolate serum pH because obviously our urine does everything it can to try and maintain the blood pH, so it's not an accurate reflection. And also, if you put a blood sample onto one of the urine strips, it just doesn't work. It makes all the little boxes too dark. I did this last week, or 2 weeks ago, up in my clinic, and I just was sitting there with like blood all over the counter, and it didn't work. So, it's just like if you have frank macroscopic hematuria, it's not going to give you much. Oops. So what else do we have lying around the emergency department that might help? I'm not sure if it's the same, if it looks the same here, but we have these little nitrazine strips that we use for measuring the pH of eyes and looking for possible amniotic fluid leaks. So they check the pH, and I can attest that they do give a rough estimate. I had a venous blood gas drawn on myself. It turns out I'm a CO2 retainer, which was interesting. And then I smeared a bit of the blood onto one of these strips, and it gave me a close-ish reading of my own pH. It was within 0.5. So it gives you a vague, broad definition of your pH, but hopefully if your patient is acidotic, if they're between 6.5 and 7, you're using other clinical signs to help you figure out what's going on. So if that's not ideal, what else is there? Well, there's this. This is the end-tidal CO2 monitors. I'm not suggesting that we intubate our possible DKA patients automatically to check their end-tidal CO2 levels, but this is a nifty little tool which is relatively cheap and useful, and this is for non-intubated patients. The monitor itself costs about $300 for like the box that you keep permanently, and then the disposable nasal prongs or face masks cost about $10 to $15 each. Oxygen goes into one nostril, I don't know if it's too small to see, but into one nostril, and the CO2 outflow is measured from the other nostril. And it's a really elegant little device. It's remarkably well tolerated. We unfortunately don't have this where I work, but I'm going to try and make sure that we do get it fairly quickly. And this allows the rate of lung CO2 excretion to be continuously monitored, which is really great because there's a high degree of correlation between CO2 excretion and the degree of acidosis in a patient with DKA. But how reliable is it, and should we use it for following pH? So there was a study in pediatric diabetes in 2006 that looked just at this. And they, like I'd said before, the first 6 hours are really critical for DKA because that's when the cerebral edema can really kick in. And so you need continuous monitoring of acidosis is advantageous in the acutely ill patient with DKA. But given that the first 6 hours or more of my case patient's trajectory in DKA was going to be where there were no labs, we need something else to help us. And it turns out that you can follow the acidosis with the end-tidal CO2 monitoring more easily than with the blood draws, because this obviously can change minute to minute. And so if you're only doing labs every 4 hours, you're only finding out those intervals every 4 hours. Whereas if you're actually looking at the end-tidal CO2 levels, then you can actually make adjustments as needed on a much shorter time period. So normally in an ICU or big CER, we're asking for more frequent blood gases, but this is obviously invasive, it takes time for nurses and means high cost for the system, and it means you need a lab. So if there's any way that you are able to, in any of your centers, to get one of these little end-tidal CO2 monitors for non-intubated patients, then I think it'd be a very valuable investment. So a quick recap here. We've assessed the patient's capillary glucose level, we've addressed their fluid status, we've used our clinical judgment and maybe a capillary ketone meter to assess for ketones, we've used the end-tidal CO2 monitor, maybe some nitrazine paper just to sort of confirm and to estimate the pH. But of course there's this one key branch of the DKA algorithm that we have yet to tackle. And you know which one I'm talking about. Yes, it is potassium, the one that we all hate. So if you're like me, I love the idea of using things other than labs to figure out complicated parts of my patient's physiology that, might completely kill them if I screw up. But by that, I mean I really love the idea of this. When I'm dreaming about being like a MacGyver rural doctor in the middle of the night, that's what I think about. But the reality is way different and a lot more stressful. Getting faxed copies of ECGs from nursing stations for a patient that I've never laid eyes on is not my idea of a good time. But it's important to understand the patient's symptoms and figure out how their ECG can help us. So let's tackle this issue of the potassium. We all know that we're not supposed to start the insulin drips until we know the patient's potassium, because we can make their potassium go way down by giving them too much insulin. But if we can't check their potassium, what are we going to do? Well, start just by seeing if they void urine, because that's going to help you to start with, because if they can't void, then you're even more worried about the hyperkalemia and AKI. But you can look at your patient and assess them clinically. It's really hard to know, unfortunately, when symptoms are going to start, though. If a patient has chronic kidney disease, they may not start getting some of these symptoms until their potassium is over 7. But if it's an acute onset, or if they've got healthy kidneys, this could start a lot lower. So you have to really be on the lookout for some of these physiologic changes. Look for muscle weakness and paralysis. It's often ascending, beginning with the legs and the trunk and the arms. Sometimes it mimics Guillain-Barré syndrome. And usually one of the things that can help you distinguish it, though, is that sphincter tone and cranial nerves remain intact. So that's one way of helping you. It's rare to see respiratory muscle weakness in these cases, but you can see dyspnea. Put the patient on a cardiac monitor, look for arrhythmias, look for cardiac conduction abnormalities. and then get an ECG. What will likely be the first of many ECGs if you're managing a case of DKA far from a lab. But what are you going to look for on an ECG? Well, you're going to see the tall peaked T waves with a shortened QT interval. And then as the hyperkalemia gets more severe, you're going to see this lengthening of the PR, and the QRS duration is going to get longer. The P wave might actually disappear. And then the QRS can widen until it gets into this really sine wave pattern, which is really scary, and everyone starts to freak out. And of course, it can lead to ventricular standstill with complete absence of any electrical activity, which is obviously what we're trying to avoid. But of course, all of the research, like just when you think, oh, I can base everything on my ECG, you look at the research and it says that the progression and severity of ECG changes do not correlate well with serum potassium concentration. For instance, some patients who have chronic kidney disease could have a potassium of 9 and might not show any ECG changes. That would be rare, but it is possible. So where does that leave us? It sounds pretty awful. It basically leaves us doing repeated ECGs. Leave the ECG stickers on your patient. They're going to be having ECG after ECG after ECG because you need to do the trending of the ECGs to figure out what's going on. So we're going to look at a couple of these. So here you see the classic peak T waves. And these are ECGs given to me by the kind folks at MRAP. Some of the staff there have sent me their scary hyperkalemia ECGs. And then we have more of the peak T waves. And then you're starting to see that the P is starting to disappear. And then there's the scary sine wave, which no one wants to see. All right. So now that you're totally freaked out, imagining your patient's going to die from hyperkalemia, take a breath. And now let's think about what happens if they start crashing from hypokalemia instead. Now, it's rare to be hypokalemic when you're in DKA, but it can certainly happen. And they might start off hypokalemic or even normokalemic, which of course is risky when you're in DKA because then you're going to give them insulin and it's going to make it worse. So what are some of the signs that could help us figure out if you've either made them too low or if they're starting off too low? Oh, sorry, that was a scary sine wave pattern. Sorry. So, symptoms don't usually appear until the potassium is under 3, but it depends again on how rapidly the potassium level changed. If it's acute onset, you're going to get severe muscle weakness. It tends to be lower extremities, going to the trunk. The upper extremities can worsen to the point of paralysis. Does it sound familiar at all? Does it sound like very much like what can happen with hyperkalemia? Exactly. This is a major problem because it's extremely hard to differentiate. They might get more muscle cramps with hypokalemia, and they can get respiratory muscle weakness. So that is one way of helping to differentiate. But it's not foolproof. So you're going to want to be doing an ECG on these folks. And for them, the whole range of ECG signs can pop up with hypokalemia, and it really depends a lot on their underlying renal disease or cardiac disease. But the classic textbook things that you're going to hear about are this nice depression of the ST segment, you get a decreased amplitude of the T wave, and then an increased amplitude of the U wave, which the wave occurs at the end of the T wave. And then you're going to see these sort of gradual changes. You might get sinus bradycardia, you might get junctional tachycardia, you could get AV block, VTach, or VFib. So all things that you're really not wanting to do. So again, unfortunately, I have no magic answer for this part. You just need to do serial EKGs. You need to be trending this. Because, as you know, if it's too low, the potassium, then you're going to want to replace it. But also, if the potassium is under 5.3, you want to replace it with an infusion. So if you have a normal ECG and the patient's able to void urine, at the very minimum, start an infusion of NS with 20 milliequivalents per liter of potassium in that IV fluid, at the very minimum, and then you can trend. If you think they've gone hyperkalemic and you need to give a little bit more, you're able to, but at the bare minimum, if they have a normal ECG and you have no reason to suspect that they're hyper or hypokalemic, then that's what I would start with. But keep doing the ECGs. So in terms of, we've been able to do a lot of things with very limited resource. We looked at volume status, glucose, ketones, and I'm not suggesting that you shouldn't be nervous about these people because, taking care of them when you don't have labs definitely makes us nervous because they're sick, they're in DKA, and you're treating them without precise physiological measurements, but you're not helpless. There are tons of things you can do. And before I forget, don't forget you also need to think about what caused the DKA. So while they're in your shop waiting to be transferred out, look for signs of infection or physiologic stress. Look at any issues of compliance. And For any of the rural doctors out there, I just wanted to promote these two sites. There's the World Organization of Family Doctors, wonka.net, and then there's the Society of Rural Physicians of Canada, but which is open to all the world, and they have a listserv, so srpc.ca, and you go on there and you can ask questions, and people from all over the world will help answer your questions, and they have sometimes live events, and it's a fantastic resource. So miigwech, which is a Cree way of saying thank you from where I work up in Sassavie, and those are my ways of contacting me.